Okay, so I'm doing it in the order that you are on my screen. I'll just ask Thomas, can you introduce yourself first, please?
Hello, my name's Thomas Williams. I'm a paediatrician and a clinical lecturer at the University of Edinburgh. I've got an interest in COVID virology. I did some sequencing at the start of the pandemic, and then I recruited to one of the vaccine trials. And now there's a lot of interest in vaccination for children. So kind of the front line of queries and anxiety and questions about paediatric vaccination.
Great. And Megan?
I'm Megan McLeod. I'm a research scientist and senior lecturer at the University of Glasgow. And my research group study immune memory. So that's how infection or vaccinations change the immune system so you're better prepared to fight disease.
Fantastic. And last but very much not least, Emma?
Okay. My name is Emma Thompson. I'm a clinical professor of infectious diseases at the MRC University of Glasgow Centre for Virus Research and also the London School of Hygiene and Tropical Medicine. And I do my science on virus genetics and how viruses work. And I look after patients with adult patients with COVID-19 as an infectious diseases doctor.
Fantastic. Thank you very much. So hopefully you can see that our panelist has got a great varied experience, so we can come at this question with lots of different angles. So I think we'll just get started right at the basics, just in case anybody didn't attend our event last year. So maybe Megan, can you just talk us through briefly how a vaccine works and how it protects us against COVID infection?
Perfect. I'm happy to do that. Vaccines contain very small amounts of the virus or the bacteria that you're trying to protect someone with, and you inject it often into the arm, but sometimes up the nose if you're a child and you get the influenza virus vaccine. And that introduces the little bit of the virus or the bacteria into your body, and your immune cells find out about it. They learn that this new substance has been injected and they make an immune response. And they learn to recognize that particular virus. So when people have been immunized with the COVID-19 or SARS-CoV-2 vaccines, their immune system has learned to recognize the SARS-CoV-2 virus, and that they increase in number. And that means that you have lots of these immune cells and immune molecules patrolling around your body, waiting for you to be infected. And they can act really quickly to protect you if you are actually infected with the virus. And that means sometimes that you can stop the infection entirely, but often it means you might get a small infection and your immune system is ready and primed to protect you. So you will get less disease. The virus or bacteria is less likely to make more copies of itself. So you're less likely to transmit the infection to other people.
Brilliant. That's really great description. Thank you, Megan. So we've got our first question come in from the audience already, and I think this is a nice place to move on to that, which is the question of whether people who are dying with COVID on their birth certificate and being recorded by government in England, Scotland, Wales, across the UK as dying as a COVID death, how many of these people are actually dying from COVID, and how many of them are people who are unwell or they pick up the COVID infection when they're already in the hospital. So I think it's a good point actually made by one of our audience that this is kind of important for us to know about how efficient and effective the vaccines are. So maybe Emma, I think this is mainly talking about adults. Maybe you can give us a picture of what the current situation is on COVID deaths. I guess most of them are probably taking place now in hospitals.
Yeah, no, it's a really important question. And so there are data available on some part of this question. So I've been involved in tracking the cases in Scotland, and the English cases are tracked through the UK Health Security Agency, which is the new name for Public Health England. And so you're really right. And in the beginning, when we started to look at how well vaccines were working and something we call vaccine effectiveness, our kind of mainstay has been to look at test negative and test positivity. So for everybody that goes to get a test, are they testing negative or are they testing positive? And we know that that Omicron is all types of Omicron are quite immune evading, and so the vaccines are not terribly effective at preventing infection, although they really do protect you from infection to a certain extent. What's really a better sort of readout of our current situation, and what we need to do about regulations and everything, is to see whether or not, as you've inferred here, is Omicron actually killing people or putting them in hospital? And the answer to that is yes, it is, but much less so than Delta, for example. And so there are papers, and one of which I've written, which show that the severity of illness associated with Omicron is much less than with Delta, which preceded it in the UK. And we can only really get that kind of information through data linkage. So that means that some of this data that we have on Omicron is coming from state-of-the-art methods that really weren't actually available in the NHS or in public health previously. And so it was universities, including Glasgow and Edinburgh University St Andrews in Scotland, who really contributed to this response and developed good sequencing methods for this virus. And now that has actually all been transferred into the National Health Service. So they are now rolling out sequencing, and they can do 5,000 sequences a week in Scotland. So it's quite high throughput. And it's now possible as well to link that information, that genetic information, with patient records that are anonymized. So obviously we have to be very careful about data protection. And so the mechanisms for linking that genetic information with how well people were doing were not actually in place 2 years ago, but they are now in place to allow us to do that safely, so that people's data are protected and through the right sort of channels and routes. And so, yeah, we know actually that it's definitely the case that there are more people now who are dying with COVID than there were of COVID previously, if that makes sense. And just also, I guess, Thomas might comment on this, but having looked after patients in the very first wave, and then again now, in the first couple of waves, we were seeing people really gasping for breath and requiring a lot of oxygen, and then having to be ventilated and sent to intensive care, which was a very unpleasant experience for those of us who were involved in looking after people. It was really quite, it was a difficult situation to be in, and the hospitals for a while were quite overwhelmed. Now it's the case that we're not using nearly so much oxygen, and we're very rarely having to send people to the intensive care unit. And so Omicron itself is a less severe variant of the virus. And in fact, we know why that is as well. I could talk about that later, but it's actually all to do with the mechanics of how the virus gets into cells. And so the biology of the virus has really fundamentally changed. It gets in much more now into nasal cells, so cells in your nose where it lives, rather than in the lungs, which is a big problem and can cause severe pneumonia, which was the big issue with previous waves. Hopefully that partially answers your question, but we do need to do a lot more with data linkage. We need to get the balance right. We need to be able to improve sort of cutting edge state-of-the-art technologies and get them into our health service fast. And that actually has happened. It has happened. We just need to keep up that momentum, because there are other ways in which we could use genetics to better understand what to expect from other infections as well.
Great, thank you so much. I think that's really exciting that obviously this horrible period in all of our lives has driven to some positive change. But yeah, definitely need to keep that momentum up. So I think that's a great outlook on the adult population of patients. Maybe Thomas, you can give us an update about children. So a year ago when we were having this conversation, the general narrative was that children didn't seem to get COVID. If they got it, they weren't very sick. We were talking about not having to vaccinate them at all. Obviously, that's changed quite a lot in the past year. So what is the current situation of COVID in young people?
Okay, so I can speak about Scotland because that's the place I know the most about. I think the most important thing is that COVID doesn't affect children that badly, and that's been confirmed. So most children will either be asymptomatic or have very mild infection, like a cold infection or a flu-like infection. The other thing to say is that most children have now had COVID. I think so 80 to 90% of children across the UK have now had COVID. That complicates vaccines, which I can come to in a second. And the most severe complication from COVID is not the infection itself, but this rare kind of reaction to the virus called PIMS-TS or MIS-C, which is where your body overreacts to the virus and causes a kind of hyperinflammatory response. We've audited Scotland-wide data, and so in the first year of the pandemic across Scotland, there were 20 kids admitted to intensive care in Scotland, across the whole country, and that's kind of, we know that for sure because there's only 2 intensive care units in Scotland, so there are 20 children who are sick enough to go to intensive care, and half of those had this condition called PIMS-TS, and not that many of them were sick enough to need this kind of intubation ventilation that Emma was talking about. I think around just a handful really needed that. In the second year of infection, I think a lot more children got infected. So in the first wave, I think children are pretty protected from infection because they're all staying at home.
Yeah.
And there were lots of adult infections, but we didn't really see a sweep of kids being infected. We saw that more in kind of the autumn of 2020, autumn, winter, when we had that second peak. And I think because kids go to school, yeah, and so they were more exposed then. And then this year, I think we're worried that as COVID went through the third and fourth wave, we see a lot more cases of PIMS-TS and a lot more cases of severe COVID. But I was just looking at the data last night, in fact, and there's been quite a few cases, but probably only another 40 or so in the second year requiring admission to intensive care. And probably more of those in the first wave were PIMS-TS than previously. And people, I think, aren't really sure why a lot more children got infected, but we didn't see a resultant spike in PIMS-TS cases because we haven't vaccinated children in this country. It could, some people think that maybe the virus strains have changed, like Emma says, and children are less likely to have this kind of pathophysiological response. Or other people think, well, so many kids have been infected over time that actually there's very few children out there who haven't been infected. And if you're going to get PIMS-TS, you probably get it the first time around, you're not going to get it a second time around. So by the time we came to our kind of third and fourth waves, most children had it, and therefore your chances of getting PIMS-TS are pretty small. The one thing I think we did wrong, and I'm not sure I thought at the time there was a right answer, but I think we could have prevented pretty much all of the cases of PIMS-TS that we had this last autumn and winter and spring if we'd vaccinated kids. The COVID vaccine is really effective in preventing PIMS-TS. And if we'd done like America had, or France or other European countries, and vaccinated kids from the age of 5 upwards, we could have prevented these, probably most of these 40 cases of PIMS-TS if we'd had universal vaccination. Whether or not we would have achieved that it's hard to know, but I'm 100% confident that we're not going to achieve 100% coverage with childhood vaccination from now on, because people are so conflicted about it. And I get my colleagues at work asking about it, and I'm not sure there's a right answer, because I think whether you've had the vaccine or COVID, having the infection once or having the vaccine gives you some protection.
Right.
And therefore the benefits of vaccination, if you've had it, are kind of more marginal. And they were pretty marginal in the first place, really, because the number of deaths from COVID has been really small in Scotland.
And that's specific for children?
Specific for children, yeah. Sorry. Right. And then the other thing is that the children who are in our study, we looked at hospitalizations for COVID in the first year, and over half of them were in under 5s, so kids who wouldn't benefit from the vaccine. So I think going forwards, I wonder if we might start to have this pattern where newborns and infants who haven't seen COVID before come into hospital with it in the first year or 2 years of life, and then other kids kind of have had it and don't have it so seriously again. But it's really hard to know what will happen and then what the appropriate response is. And I think JCVI, which is the vaccine committee, wasn't convinced about the risks and benefits back last summer. In retrospect, perhaps that we should have advocated for universal vaccination, but now we're in the situation where it's really complicated.
Yeah, of course.
Happy to answer any questions. Happy, and also Megan and Emma's thoughts on that.
Yeah, definitely. So I think one of the things that I just want to make sure that we've got clear, this syndrome that you're talking about, MTPS.
MTPS.
So that's a overreaction of the immune system, did you say? So I wonder maybe, Megan, if you want to, I'm not sure if you're familiar with the syndrome, but maybe explain how this hyper reaction of the immune system can take place and how it can be a problem.
I'm not a medic, so I'm not going to have an expert explanation of the disease, but certainly sometimes our immune system is often a balance, deciding how much to respond and when to respond. And my suspicion is, and Thomas can correct me, is that the immune cells make such a big response that they're making lots of molecules that we call cytokines, and those are really useful in an infection to tell different cells in your immune system that they need to get ready and to make an immune response. But if there's too many of them, then you get a kind of sickness feeling. So often the fatigue that is caused when you have an illness, or in some people after they've been vaccinated, is caused by these molecules. And if you end up with too many of them, then you overwhelm those feelings of fatigue and illness and fever. Is that kind of describing, Thomas, the response that these kids have?
Yeah, so the response happens not during COVID infection, but a few weeks afterwards, kind of 2 to 4 weeks afterwards. And it seems to be something about having been exposed that in some children who are probably genetically predisposed in some way, so just some children different to others, that means that they're more predisposed to having this kind of hyperinflammatory response. So when you do their blood test, that their inflammatory markers are really high. They're very non-specific markers of too much inflammation, so tummy pain, vomiting, rash, red eyes, and often it's not really respiratory or kind of breathing problems that they have. It's more just the problems of this too much inflammation going on in the body.
And we are, as I said, the immune system is very much a balance, and often it has a go signal, and most of us have stop signals to stop it and return you to a normal level of inflammation and be at rest. Potentially those kids have genetic differences that mean those stop signals don't work so well, and so they're more at risk potentially of having this hyperinflammatory state.
Right. And can that happen in adults as well?
I'm looking at the medics.
Emma, I'll just unmute you.
Yeah, probably, but very rarely, and
Right.
usually young adults.
Okay. Okay. Is that because when people age, their immune system is not as active?
When we're young, particularly between birth and 2 or 3 years of age, our immune system kind of tunes itself in based on the infections and surrounding environment that we're exposed to. And if you tune yourself correctly, then you are more likely to make a balanced immune response. There's some evidence now that if you grow up in a very clean environment, so if we have animal models where we remove them from all germs, those animals make very large immune responses and changed immune responses following an infection that often leads to pathology rather than protection. And we think there is a similar thing that happens in children who don't get exposed to everyday bugs that you get exposed to just through your normal life.
So it's all about having a balance with the immune system. It needs to be stimulated enough, but not too much.
Exactly.
Okay, so we've got a question come in about how the vaccines exactly are stimulating the immune system. So I know you've just briefly, I know we've mentioned it already, but briefly the question is asking about whether vaccines stimulate B cells and T cells or just one arm, and whether that's the case for COVID vaccines and whether we could change the vaccines to overcome that.
So I have to be careful because I could speak for about 4 hours just on this one question.
I'm sure.
So B and T cells are those two big immune cells that we call adaptive immune cells, and they have these very specific receptors on their cell surface. So these are proteins that can specifically recognize SARS-CoV-2 virus or influenza virus or salmonella. And so we train them to learn about the pathogen from the vaccine or from an infection, and they're the ones that will live for a long time and protect you in the future. B cells are the ones that make these antibody molecules that we think are really important if they can recognize in COVID-19 the spike protein and stop you from being infected. And then the spike protein is the one that the virus keeps changing, so we're always running behind it. And then T cells are my favorite adaptive immune cell, and they're come in two flavors. One flavor are the helper T cells, and they're really important to help the B cells make those antibody responses. And then the other flavor are killer cells, which often come to the place where the infection is, and they will kill cells that have been infected with the virus. So all of those three cell types are really important. Pretty much every vaccine that we have stimulates a B cell and a CD4 T cell response, because we can measure the antibodies that get induced, and we know those antibodies wouldn't exist without the CD4 T cells. What's been really nice about the new vaccines that have been generated for SARS-CoV-2, so those are the messenger RNA vaccines and the viral vector vaccines, they're really good at stimulating all three arms. And we, I think immunologists and maybe also virologists, Emma can correct me, have been super excited about the fact that these newer type of vaccines are able to stimulate all arms of the immune system. So we are really happy about the COVID-19 vaccines and their ability to stimulate the immune responses. And although we are now getting reinfections, that's not because the vaccines were poor, it's because they were targeting the spike protein on the original SARS-CoV-2 virus that's now changed. And we are playing catch up with our immune response against that very special part of the virus that it uses to infect our cells.
Great, thank you so much for explaining. That was really clear. I think that is a great moment to ask Emma to perhaps talk about the development of the variants, the changes in the spike protein specifically, I guess, are kind of the ones that we're interested in this context, and whether the vaccines are going to be updated for new variants, whether we're going to have to update them every year. How is that going to progress going forwards?
Yeah, I mean, basically, we've had these sweeps, waves of different variants, and early on, way back in March 2020, we spotted just sort of single changes in the genome of the virus. So the genome is the sort of blueprint, the recipe, if you like, for making a virus, which is made of protein. So a virus is actually just a bit of genetic material wrapped up in protein, and the genetic material has the recipe for that protein in it. And when the virus divides, that genetic material, it makes it, there's always an error pretty much every time, you know, every sort of certain cycle of number of replications of the virus. And that randomly leads to changes in the shape of the virus. It's a sort of a shape shifter. And the spike protein, if you remember the sort of BBC image of the virus as it twirls around, you can see those little blobs on the surface, and those are the spike protein. And the spike protein is, it sits on the surface of the virus. It's actually the key to get into the human cells. So it inserts itself, it binds to the proteins on the surface of human cells, in the lungs in particular, also in the nose and other parts of the body, but predominantly in the respiratory tract. And changes in that, in the shape of the spike protein, can mean that the virus can become less easily neutralized or tackled by antibodies. And so we've watched over the last 2 years the virus gradually change shape, and each variant that with these new variants, the first one being Alpha, which came from Kent in the southeast of England, and then various other variants as they gradually emerged. So Delta was the next big one in the UK, and that came originally from India or around that area. And then, of course, we now had Omicron, which originated in the South African region, not necessarily South Africa. And those variants have been steadily different, and Omicron has been by far the most different. So it's got a huge number of changes in its shape. And we saw that with our early warning system, the sequencing early warning system in the UK, and got quite worried that this could be quite a threat. And indeed, it is really immune evading. So it's if you've had 2 doses of vaccine, you're really badly protected against Omicron. But if you've had 3 doses of vaccine, you are really much better protected, and actually against severe illness, well over 90%. So the vaccines actually work very well to prevent severe illness, but much less well at preventing infection. And that's because the shape of the spike protein has changed so much that the antibodies which are trying to bind to that to kill the virus, if you like, are finding it very difficult to make contact because the shape of the spike has changed significantly. And so the question about whether we need to give updated vaccines is one which is at the moment being addressed in clinical trials. One of which we're running in Glasgow, for example, and we've been running a trial of the Moderna Omicron vaccine, so based on the Omicron variant. And we'll know at the conclusion of those trials how much better that vaccine is at preventing infection and preventing severe illness. The difficulty that we face is that what's good for one variant may not be that good for another one. So if we protect really well against Omicron, unfortunately, at some point, another variant's going to come, and that may escape. And so, yes, I think it is likely that we will need to update the vaccines. I don't think it's going to be yearly. We may need to be boosted yearly, but I don't think we're going to have to change the vaccine itself yearly. And that's actually a surprise and something different from what I said last year, because I didn't think that just giving 3 doses would make that much difference against a virus which has changed shape so significantly. And I don't think I was alone in that thought, and that in the end turned out to be not quite right. Actually, giving the 3rd dose of vaccine really does improve the response against Omicron, and even though the vaccine is based on the original variant which emerged from China in 2019. And so I think boosting, yes, changing the construction of the vaccine, yes, but probably less frequently.
Fantastic. Thank you so much for that explanation. So I guess kind of linked to that, sorry, I'm just checking the question, where's it gone? So we've had a question about how people, whether they're vaccinated or not, have gone this whole time and have never tested positive, and they can't identify a point where they think, oh, I was sick there before testing was widely available. So this is an open question to whoever feels that they want to answer it. Is there any current thinking as to why some people have just gone the whole pandemic essentially and not caught COVID yet, or not tested positive?
I can make a start on answering that, and there's some nice data from some studies on healthcare workers, and they were being frequently tested by PCR for having SARS-CoV-2 because of their job, and they were also looking in the blood of those people to see if they were making an immune response against the virus. And often when we look in the blood, we're just looking for those antibody responses because that's the easiest way to test. And these individuals were not showing that they had been exposed to SARS-CoV-2, and they were not coming up positive in their PCR tests, but they were environments where they were frequently exposed. And when they looked a little bit more closely at the blood, and this time they looked at the T cells in those individuals, they found that their T cells were being stimulated inside them. So they were being exposed to the virus and they were making immune responses against it. So in those individuals, they had T cells, probably from some other coronavirus, not from SARS-CoV-2, that were not just protecting them from disease, but actually stopping them from getting fully infected enough to make their antibody response turn on. So we think that some people had this pre-existing immunity because of their exposure to other coronaviruses that may be protecting them against infection.
That's really interesting, because I remember right at the beginning of the pandemic, everyone discussing, because there are other coronaviruses that just cause common cold, right? And I remember people discussing whether were going to provide any sort of protection. So it's really interesting to hear that they definitely do. I
think the thing is, it's very hard to know who those people are.
Yeah.
And it's a small minority of people. Most of us who are exposed to the coronavirus virus are likely to get infected. Many of us won't get ill, and those of us who are unvaccinated are likely to get quite ill or quite severely ill.
Right, great. Okay, so hopefully that answers the question, but if you're in the audience and you don't think we've quite caught the nuance of your question, please do pop another question in the chat, and we're happy to come back to it. So we've got another question here, which I think a lot of people are currently talking about. So Thomas, probably this is an area for you to look at, but other people feel free to jump in. So you kind of already mentioned about childhood vaccines. So first of all, maybe you can just let us know exactly what the current guidelines are and what young people are being vaccinated and who aren't, because I know there's maybe a little bit of confusion about that. And then also you did mention, there's a lot of uncertainty about it. Maybe you can just briefly outline what you think the main issues are in terms of vaccinating young people.
Yeah, so as I said, we've diverged a bit from the other countries and our vaccination policy, but as it stands, teenagers were advised to get vaccinated last summer. So that's 16 to 18-year-olds, and then 12 to 15-year-olds were advised to get vaccinated. And then it took a long time to decide that we wanted to vaccinate 5 to 12-year-olds. Initially, we decided that we should vaccinate vulnerable 5 to 12-year-olds. So children with kind of profound neurodisability, we know to be at slightly high risk of severe disease. So the advice was to vaccinate those children. And then since kind of February and March, the advice has been to vaccinate all 5 to 12-year-olds. But that's been rolled out in a kind of piecemeal manner. It hasn't been the same drive that we had to vaccinate adults. So I know from experience as a parent that if you're the parent of a 5 to 12-year-old, you get a letter inviting you to sign up for a COVID-19 vaccination. The vaccines that are licensed for use in kids is the Pfizer vaccine, which is the mRNA vaccine that Megan was talking about. Really safe vaccine. Initially, there were concerns that it might be associated with this condition called myocarditis, which is where your heart becomes inflamed, particularly in teenage boys. Israel was the first country to really vaccinate younger people, and they found a slightly higher risk in young teenagers and young men, mainly males, up to maybe up to 1 in 100,000 men who got vaccinated to get myocarditis, this heart inflammation. That is less common in younger children, and it also seems like if you space out the dosing of the vaccine, it's less likely. So the Pfizer vaccine was initially recommended to be 3 weeks apart, which is what America did and Israel did. But the UK, we've tended to vaccinate a longer interval, which immunologically, there's a big debate last year as to whether it was a good or a bad thing. But I think we've learned that it was probably a good thing to give the body time to mount one immune response and then hit it again 3 months later. So the vaccine's licensed, it's recommended, it's really safe. I think they say 2 cases per million vaccines of myocarditis in children, of which the majority will be very mild. And the big question is, people ask me is, should I vaccinate my child? It's strange to me that there's so much anxiety about this vaccine when we don't really question other vaccines. The MMR vaccine, people have questions, but other childhood vaccinations, I don't really get that kind of response from parents as to, should I give my child their 8-week set or their 12-week set or their 16-week set? It's kind of not really a thing. I think we're kind of socially just used to giving kids those vaccines, and we have introduced new vaccines in the last 10 years. For example, for meningitis type B, for rotavirus, and there hasn't been any kind of wave of disquiet or questioning. People just kind of taken their stride and carried on with it. I don't know whether it's because people are talking about vaccines so much or because the kind of anti-vax lobby has kind of grown in strength and confidence during the pandemic. So people are approaching this differently to different vaccines. Normally, with a vaccine, we say we recommend it and people would take it and that'd be it. And there'd be kind of a small minority who'd say, oh, not sure I like vaccines, or I don't believe the science, or whatever it is. But with COVID, about 50-50, it seems that half of people don't want to give children the vaccine, including consultant pediatricians, including nurses, and parents at school saying, oh, I'm not sure, is the vaccine safe? Is it worth it? Isn't it worth it? And so when you decide whether it's worth it or not, I guess you have to break it down into the benefits of the vaccine and the disadvantages. And so the benefits of the vaccine, you've got your direct benefits, which are preventing severe disease and preventing transmission to other people. As I said, because most kids have now had COVID, I don't think anyone knows what extra benefits having the vaccine offers, like whether if you've had previous disease and get the vaccine, are you even less likely to get severe disease. But as we said, your risk is really low anyway. So you're bringing down that risk by probably a tiny amount of severe disease. The other thing is, could you vaccinate your kids to prevent giving it to granny or other people in the household? But as Emma says, for Omicron in particular, your antibodies that you build to protect you against transmission or kind of mild disease and transmission, they wane, they fade really quickly, kind of within 10 weeks perhaps. So you're only buying a bit of time for your child to not transmit the disease necessarily. And then in addition to that, there's indirect benefits. So kind of if your child is vaccinated, they might not get COVID, they won't miss school, and therefore you're enhancing education, or the classes are less likely to have COVID. I don't know, Emma and Megan might have a better idea that even if you vaccinated every single school child in Scotland, whether you would prevent another wave of COVID going through everyone. I mean, for example, I've been triple vaccinated, and I've had COVID, so it hasn't prevented disease. I was very well with it, which is great. The vaccines really do work, but it doesn't prevent me having it. And so that argument again is a bit more complicated, because if you're not necessarily preventing getting disease mildly, you're not getting that benefit from not missing school. And then if you vaccinate kids, about 10% will feel so miserable afterwards, they kind of miss a day or two of school afterwards. So then you're weighing up those two things. And then the third consideration is you've got the benefits. The risks, I think, are really small. I don't think are really worth thinking or talking about. But then you've got the opportunity cost. So you've got vaccination services that have got to give all the normal vaccines to children and adults. Rolling out a vaccine like COVID to every school child's a big endeavor. So flu gets done every year, but it's as Megan said, with a sniffer. It's really quick. But COVID's an injection, takes longer. Kids don't like injections. It's harder to persuade a class of 6-year-olds to all get their injection. And it's tricky. And I think a year ago, perhaps a bit less than a year ago, we could have said, this is your chance to prevent PIMS-TS and to prevent this kind of winter wave. Now we're in a very different situation. And yeah, I'm pretty pro-vaccine, but I find it hard to really sell it to people who are not sure. In my mind, if it reduces the risk of my child getting COVID again and optimizes their chance to be at school, it's worth it because the risks are so low. But a lot of parents, particularly when it comes to health and disease, are very risk averse, understandably, because it's their children. I don't know whether Megan or Emma have got anything to add to that.
Emma, Megan, is there anything that you wanted to add?
Go for it, Megan.
I was just going to say the difficulty is the many unknowns that Thomas has explained to us. We can't know. I think we all know that the vaccines now can't prevent infection, but they may reduce the amount of time that you're infected for. So they may reduce transmissibility because you clear the virus more quickly, having been vaccinated than not vaccinated. And they're likely to give you some kind of boost. At least we know from adults, the vaccines give you some boost to those who've been previously infected. But as far as I know, there aren't studies in kids to really track that boost and to track time of infections. That's a really difficult study to do, particularly in children. So lots of unknowns about it. I think giving a pro-vaccine message is generally a positive thing. And that's if that is going to have a good impact on parents coming to get their kids vaccinated against the other childhood diseases that do cause severe disease in a small number of children and can cause illness in many others, then that's a positive thing for us to do.
Just as a comment on that, it's funny that people's concerns about COVID vaccines seem to be really separate to their concerns about different vaccines. So at the start of the pandemic or throughout the pandemic, people were worried that COVID vaccine confidence would affect general vaccine confidence, so that you see a drop in childhood vaccination. But a colleague of mine did a nice study looking at childhood vaccination rates in Scotland over the last couple of years. And in fact, they went up. Even in this climate of COVID vaccine skepticism, parents are still very happier than ever before, in fact, to give children their normal childhood vaccinations. And yeah, you could flip that around a little bit. There's vaccinations in older children that are a little bit more controversial. So the human papillomavirus vaccination, that's to prevent cervical cancer and genital warts. It's quite cultural. So places like France have got really high rates of vaccine hesitancy for HPV vaccination. 50% of the population won't take it. There's kind of a narrative of them having very significant side effects leading to low blood pressure, kind of fainting attacks. Denmark had a big scare a few years ago where, again, half the population wouldn't take this vaccine because they were scared it was dangerous. We haven't had that in the UK yet at all. Really high uptake rates for the HPV vaccine. But people are worried if we push the COVID vaccine, then and there's some kind of adverse event or loss of trust, will that affect general trust in the HPV or the meningitis vaccines, which we equally know are safe and effective? But I think generally I agree with Megan. We should be pro-vaccine, but should we pick our battles? Is this the battle that's really worth fighting in terms of vaccination, or should we be saying actually we're more worried about measles vaccines, where measles vaccination rates are actually pretty low, and there's now a really real risk of measles outbreaks?
Great.
You know what Emma thinks?
I mean, I think that just coming to the point about parents' reluctance to vaccinate their children and people with vaccine hesitancy, rather than, I think there is a difference between people who are vaccine hesitant. I mean, nobody wants to take medicines of any kind, right? And especially when you're feeling healthy. I think that's a natural phenomenon, and then you need to understand what the risks are to you and to your family, and then make a decision. So that to me seems like a sort of very normal response, and actually it's a very unpleasant position to be in, to have a vaccine like this, a new vaccine for a new virus, which none of us wanted to encounter. So I suppose there has to be some acknowledgement that it's been a difficult position that we've all been in, and that, you know, relying on that barrier to infection is unfortunate. That, you know, it's unfortunate that we ended up in this position, and there are many reasons why the pandemic occurred, which could be discussed at length, but you know, and we might be better at preventing these things crossing our shores in the future. But I also think that we are going to have to deal with pandemic viruses from time to time, and so we have to put systems in place that are robust to help us prevent people getting infected, and vaccination is the best defense that we have. But it's not perfect, and some people do get side effects, and some of those side effects are serious, even though the likelihood to any individual person is far greater from getting the virus and ending up in hospital than them getting a side effect of the vaccine. But, you know, someone who's had a vaccine side effect, that's really important for them. And so this is vaccine hesitancy. The thing that really alarms me, though, is that there is a money-making process in vaccine denialism and sort of marketing of medicines and things to prevent infection, or to treat infection even, which are totally they're not tested in trials and they may be harmful, and people are making money from that. And it's I think that's where I have a really heavy concern. For people who feel vaccine hesitant, I think we have to engage in a lot of discussion to get through that. And it's all a wait. We make decisions about risk all the time. We make decisions about if we're going to walk in front of that car fast to get past it, and all these things we're used to. This is the human condition. We're used to making those decisions. And actually, I think we could have a better discussion. Maybe this is part of what this is about, that we actually able to discuss in a more nuanced way with this, the subtleties of what vaccines do and don't do. And it's not black and white. And I think sometimes scientists are different from politicians in this way, in that, and clinicians, in that we will always warn someone of the benefits and risks of anything we do. Politicians often quite like to have a black and white answer, and I think it's as close to black and white actually as you can get. But there are issues, as we've discussed, with vaccines, potentially very, very rare. And I think that the way that we need to discuss that needs to be to show those figures and to be able to discuss it really carefully. And but we would have had it. We've many millions of lives now have been saved by vaccines across the world, and so and we've had a handful of people who've had severe side effects. I mean, that's the data. And I do think that we have to have these discussions more often with everybody about science, and it can be difficult to communicate if you're embedded in something. It can be difficult to remember to zoom back and discuss it sort of with a zoomed out lens. But maybe this is the kind of forum that helps us to do that as scientists and get better at it.
Absolutely. Well, this is exactly the kind of thing that we're hoping with Scott's side, but there's other avenues as well. But I absolutely agree. I think that the media as well as politicians really want to have this black and white answer, whereas actually in reality nothing is black and white. There's always nuances to it, and I think we've done a great job so far exploring some of those. So we've got another question come in, which is kind of related to what we've just been discussing about the effects of vaccines, which is how can a vaccine prevent severe disease but not transmissibility? So I think at the beginning, going back to the politicians, we were told take the vaccine and we won't have COVID anymore, which I think we can all look back on and see was a very simplified message. So how can the vaccines be helping against severe disease, but you still end up getting it?
Can I start that one? Just I'll be very short. So we do measure these things. So we have this way of measuring the level of effectiveness of the vaccines against different variants. And what we know is, so we can actually measure how much a vaccine is going to neutralize the virus or stop it infecting cells. And what we know for sure, and it's very quantifiable, we know for sure that the effect of vaccines against the old Wuhan variant is really high. And the level of antibodies that you get against those is really high. When you then move to something like Alpha and Delta, you see this decrease in the effectiveness of those vaccines, how strongly they work. So they work much less strongly against Omicron. And that's been a gradual process as each new variant has come out. And so what it means is that it probably means that, if you get infected, you probably have less of the virus. You're likely to have lower viral load, so less of it in your body. It's less likely to cause an overwhelming infection. But you still may have it to a certain extent, and you still may be able to transmit it, even though the risk of you transmitting it is also lower. So if you're infected and vaccinated, the likelihood of you giving that to someone that you live with is actually quite a lot lower. And we know that from household studies. But I think it's to do with the degree to which the vaccine is able to actually completely prevent the virus from getting into cells. So, if you imagine it, I suppose, as being a blocker to the virus, you've got a cell here, you've got an antibody here, which binds to the receptor. The viruses are coming from all angles, trying to get into the cells. The antibodies are able to sort of bounce off quite a lot of them, but maybe with Omicron, I don't know, like only half or something. So you're likely to get less of an overwhelming infection if you're vaccinated, but it's not going to be perfect. And it is a warning to us that if we don't think about updating the vaccines, that the next thing could happen, and the vaccines get even less protective. I think that's what it is. There is another issue though, which is that actually there is something else in the equation, which is that Omicron is just intrinsically a less severe virus. So it homes to the nose and it doesn't home to the lungs as much. The way it gets into cells is different. And so it's actually naturally a less severe infection anyway. But I still think, when we know from measuring the levels of these antibodies that the levels are actually quite a lot lower against these other variants, but they're not nothing. So they're preventing, they're helping. I guess it's like partially treating it, if you like, but not completely. And so then your immune system, it's much easier for your immune system to fight off an infection if the vaccine's already taken care of half of it,
Megan, Thomas, would you like to add anything to that? So.
If I can just add a word for the T cells. So the vaccine is able to induce both these really specialized neutralizing antibodies, which are the shields that Emma's just been talking about. But we also have other antibodies that can be protective, but can't stop the virus from getting inside in the first place. And we have T cells, and they're a little bit lazy because they can only start working once the virus has got inside cells. So they take a little bit of time to work. So if we have some neutralizing antibody that's able to keep back about half of the virus, a little bit of virus getting in, and then those other parts of the immune system, the non-neutralizing antibody and the T cell, don't have so much to deal with, and they are primed and ready to go themselves. So it's kind of, it's like when you think about protecting a castle in the olden days, you don't just have the archers at the top and the ramparts watching for people. You have other ways to protect if anybody gets inside the castle as well.
Great. I think that's a great analogy. That totally makes sense. So we almost need to get a little bit sick to fully activate the trained up immune system from the vaccines. Fantastic. Okay. What else do we have? So we've got a question which I think relates to something that I've heard over and over again. I'm sure you all have as well, which is this question about the development of the vaccines. So I certainly hadn't really thought much about the development of vaccines and how long that took for any given vaccine, but everyone knows that the COVID vaccines were developed really quickly. I actually personally don't even know how long it was compared to other vaccines and how long they took, and it would be interesting to see if anyone else knows that, who's asking that question. But I guess it's this fundamental question of, obviously, everyone wanted to have a vaccine as quickly as possible. And so how do we know that the vaccines have been properly tested, and how did they get approved so quickly?
I can start. I think the reason it happened so quickly was money. So vaccines normally take a long time to get approved. You have to design the vaccine, you have to do the phase 1 trials, the phase 2 trials. That's where you kind of give it to a few people to see they tolerate it in the phase 2 trials, and then the phase 3 trial, which are the bigger clinical trials. Then it gets released. And a vaccine could take between 10 and 15 years to go from an idea to being done. So the COVID vaccines, there was so much money pumped into them, billions of dollars, billions of pounds. I mean, unbelievable sums of money pumped into all the big research institutes across the world, got a lot of money to really quickly make a vaccine. And the US government, for example, funded 6 different vaccine companies simultaneously to race against each other to see who would get the vaccine first, which is not dissimilar to what the UK government did. The UK government, I think, funded 4 or 5 different competing vaccines. And it accelerated parts of the process, but the parts it accelerated were not the making the vaccine, the trialing the vaccine, the different components of the trials. The acceleration was the paperwork in between. So Emma and I know some really bitter experience that if you apply for ethics for a normal kind of any kind of study or research grant, you could be sitting waiting for months or years to get ethics approved. And And then we had this really happy time, not happy in the world, but happy for us, and that suddenly the ethics panels will meet in a week and give you approval in a week. And the process was no different. It was just happening a lot more quickly. So what happened with the COVID vaccine is there was lots of competing companies, lots of money, but all the same steps got followed. It was just all the kind of waiting periods in between that got cut out. And I think it's a really amazing triumph of human endeavor, really, that we got there so quickly and we got so many that worked. And then in terms of long-term concerns about whether they're safe and whether there's any long-term side effects, I think partly because so many billion people have had the vaccine and there's been not any worrying safety signal apart from the kind of the one that Emma's talked about. We could be reassured by that. And secondly, I'm not aware of any vaccines where there's a long-term problem or side effect after the first few months. I'm not aware of any vaccine where the side effects are manifested after the first few months of being given. I could be corrected, but I'm pretty sure there's not an example of that. So I think the combination of the fact it's been given to so many people and that we haven't seen anything in the first few months and years now, I find that very reassuring.
Great.
I don't know whether Megan or Emma want to add anything.
I would agree with everything that Thomas has said, and just add a little bit of additional information. These vaccines weren't suddenly generated overnight. People have actually been working them for 10 to 15 years beforehand. A lot of work in the RNA vaccines has gone into cancer studies, where we've been trying to boost people's immune responses against their cancer. And so those have already been trialed in some people, and then it was adapted to use for infectious disease. And similarly with the AstraZeneca vaccine in the viral vector, they've been testing that in other infections for some time. So we as scientists often tell our funders, the people who give us money to do our research, that we're worried about future pandemics. And we have been having some funding over time to help us prepare for those emergencies. So finding new ways to make vaccines, finding vaccines that stimulate all of those arms of our adaptive immune system. So we haven't been sitting waiting on our hands waiting for a pandemic to come along. Scientists have been developing these tools for a number of years. And as Thomas has said, they were within that context of having the SARS-CoV-2 genetic material in them, they were new and they were tested to make sure they were safe. We just had so much goodwill and so much money that the long-term requirements for vaccine development, where we had to wait for each stage to finish before we could start manufacture on the second stage, those were taken away. But at no time were there safety things jumped over to speed up the process.
Yeah, I think it's money, it's funding. I've just also been having an on the side conversation with someone about, data collection and data linkage, and it is actually to do with funding and systems and putting those in place and making them quick and efficient. And sometimes the systems can really, as Thomas actually said, it can take months to years to get ethical approval to run a study, so the main holdup is actually in the bureaucracy rather than in the running the trial. And it is right and proper that we have to be very careful about people's data and how we use it, and that's really important. And we've got that wrong in the past. 50 years ago, I think the standards were quite low. Now maybe we need to think about how to make those systems fit for purpose, so that the system for applying to do something like run a vaccine trial doesn't prevent it from ever taking off the ground. And unfortunately, that happens quite a lot. And so it's getting a balance right, and that can be quite tricky. But it's to do with funding. You need to pay people to be able to commit time to setting up systems or whatever. And the health service now is firefighting like it's never fought before. There's a huge catch up to do to get people the right treatment that they need, and the waiting lists are huge, and it needs more funding, and we need to pay for that with tax or we need to change the system completely and have private medicine. But, you know, many of us don't believe in that. We're very passionate about the National Health Service and equality of access to treatment. And but unfortunately, it's really dreadfully underfunded, and the pandemic has just shown where the gaps are.
I feel like this is a whole other panel discussion that we could all discuss at length. But I think I'll just round that up and say, okay, so in terms of the vaccines being approved quickly, we've got prior research already being done that was then adapted to the COVID pandemic. And because everyone was on the same page in terms of politicians, the public, we had money being used to bypass the normal bureaucracy that slows these things down, and that's the main reason that this happens so quickly. Okay, we've just got a couple of last questions that I hope you will answer for us before we round off the session. So one question, I think a lot of people are thinking, okay, so at the beginning, we were, as soon as we had PCR tests, which allowed us to sequence the virus that each individual person had, so we could see exactly what the genome, the genetic material of the virus was. We could track the changes, we could identify the new variants. Everybody who was potentially at risk was getting a PCR test. Obviously, we had PCR tests at the airport, in the library, all over, whereas at the moment, the guidelines have changed and it doesn't seem like PCR tests are even being recommended anymore. So I tested positive on lateral flow about 6 weeks ago, and I checked on the NHS Scot website and it said, you don't need a PCR test. So question is, how are we going to track the variants? How are we going to identify changes if people aren't being sequenced, if their virus isn't being sequenced?
It's a big problem. We need to do it, and the best way to do it would be to randomize people to some people having a PCR test and us sequencing it. That would be the best way to do it. We do have to cut the costs associated with testing, probably, because it's it's going to bankrupt the government in the end. But we also need to think about intelligent testing, and the best way to do that would be to do randomized testing, so that we could keep our eyes on the virus. That we really do need to do that. It's urgent that we do that. I mean, we already are looking at a new wave coming potentially soon, and with the new sort of new variants BA4 and BA5 and some of the recombinant variants XE, XD and so on that we're tracking carefully, it's very likely that we'll get another lift in infections, and we do need to look out for it. Otherwise, we won't be able to warn people early on about how well the vaccines are likely to work and how severe the infections might be with the virus. So it's randomized. So it would be great if, like, you know, if all 4 of us tested positive and then one of us might be told to go and get a PCR test, and then that would be sequenced. That would be the best way to do it.
Is that something that the government is looking at, or is it more something that's going to be, I know there are some kind of long-term studies, like the Zoe COVID study, for example, where people are tracking their symptoms and then they can get a PCR test through that?
Funding's been cut, Kathryn.
All the funding?
For Zoe got cut 2 weeks ago, yeah.
Oh, did it? I didn't hear about that.
Yeah, there have been lots of cuts.
Yeah.
There's some testing still happening, but it's not at the levels that we would like. Probably it's lower than we would like.
So does that leave the UK specifically at risk of a new wave with a new variant that we're not prepared for?
I think it puts us at risk of not identifying that variant early. You know, we're at the same risk probably of getting the variant, but spotting it early, it will come late, because we'll only spot it when people are hospitalized.
Right.
So that is potentially problematic. Yeah.
Okay, unless we get any other questions in, I've just got one last question to ask, which is about long COVID. So a few months, I guess, into the pandemic, we started hearing this term, long COVID, where people have COVID, they recover, and then they have ongoing issues. So a lot of tiredness, breathlessness, and there are people who even a year or so, even longer later, are still experiencing these problems. Obviously, we're now 2 and a bit years into the pandemic. Do we, as a, does the health community have any more of an idea who is likely to get long COVID, why it's happening, and whether we're going to be able to treat that?
I just start with my answer for kids, which will be really short and sweet. So we were worried about long COVID in kids, and I actually wrote a research grant proposal for quite a lot of money to study long COVID in kids. And so we thought about who we'd be testing. We thought we'd do lots of complicated physiological testing for kids who'd had COVID, so exercise testing, lung function testing, scans. And then we almost but not quite got the funding. But the legacy from that grant application was a very detailed kind of guideline for what to do with children who were those concerns about long COVID. And our expectation was that there would be a huge number of children, but at least some children referred for long COVID, but they haven't materialized. They haven't appeared. It's really strange. It doesn't really seem to happen in kids. And I do a pediatric respiratory clinic, which is where kids with long COVID would be referred to. So children with breathlessness or any other respiratory problems. And we see maybe one every few clinics, hardly any. It's one of the few good news stories of the pandemic is kids don't seem to get long COVID.
Okay, great. And what about adults?
Well, adults do get long COVID, and it's very difficult to predict who those will be. And in fact, many people who've been hospitalized remain ill. We know this now, even a year later. And so the effects of COVID are really important to study further. And what's important is that we don't fully understand the mechanism behind why people are taking a long time to recover. So anyone who's been in intensive care will take a long time to recover from any illness. So that's part of the problem. But there's something more than that with COVID-19, I think. And so there are several sort of hypotheses, and Megan will probably want to talk about like the immune system. So people with long COVID may have a sort of more activated immune response than someone else. And the reasons behind that are not clear. So one of the things that I learned in my career, and this was through a case of Ebola virus that I looked after, is that the dogma isn't always right. And so like RNA viruses like SARS-CoV-2, which causes COVID-19, and Ebola virus and all these other viruses like flu and things, you're supposed to get them and then they disappear out of your body forever. And they're not supposed to be very stable, and you should just have an infection for a few days and then that's it. You either get better, you die or whatever, but you don't have it for a long period of time. We've started to learn that that's not the case, and my first learning with that was with a case that became quite publicized of someone who had Ebola virus that came back to Scotland with Ebola virus and then had a relapse of that infection 10 months after recovery. And she had the infection in her central nervous system, which is what we call an immunoprivileged site, where the immune system, the antibodies and the T-cells can't get in. And so the virus was able to just linger there, even though it wasn't causing a problem. But then something caused it to start to divide again in the body and caused illness again. And she became very unwell a second time. And anyway, what I'm getting around to saying is that I think that some viruses do persist longer than we expect, but it tends to be in sites that we find it more difficult to sample. So it can be like in the central nervous system, so in the brain and the fluid surrounding the brain, or it could be in men in the testes, which is an immunoprivileged site. It can be in other parts of the body which our immune system doesn't get into. The eyes are another sort of place where the virus can hide, and we don't generally stick needles into people's eyes or anywhere else where the virus might be lingering. So that means that it's difficult to tell, but it could be that people with long COVID actually are having prolonged infection somewhere hiding the body that we're not so easy to access. And that's one theory, but certainly, it needs much more research. Or it could just be that you have an immune response it's not responding to an ongoing infection, but it's just triggered and gone a bit crazy and difficult to calm down. But maybe Megan can answer that more technically than me.
I think I'm going to more or less repeat what Emma's just said, and that we, as exactly as Emma said, that we have this textbook idea of how viruses work and how they get cleared by our immune system, but they can persist. But I think the difficulty with long COVID is that it will look just slightly different in different people. And so it's going to be really hard to pin down exactly what's going on. And I suspect we'll see probably a bunch of scientific papers come out in the next few months to years that give us more description about what long COVID looks like in terms of the cells. But most of that will be information about what's in the blood of those individuals, because that's the most easy site that we can access. And it may be that then we miss what's really going on in the lungs or in other parts of the bodies that aren't easy to access. As well as the virus still sticking around, it may be that proteins, so the products of the virus, are still held by immune cells somewhere in the body, and they continue to stimulate the immune system. And we know from animal studies that some proteins get held inside some of our immune system for months to years. So we may not be able to find the genetic material of the virus anymore, but its proteins may be present and keep stimulating our immune cells. So that individual keeps having those cytokines that I mentioned earlier, those molecules that warn our immune cells to do its job. So those cells keep getting the messages to keep going, and we don't get those resolving stop signals that would normally get rid of those symptoms that make us feel unwell.
Great, that's a really thorough explanation. Thank you everybody for your input on that. I guess with everything in science, the more we understand it, the more likely we are going to be able to treat it and hopefully cure it with everything. Okay, so I think we haven't got any more questions come in, so I think this is a good place to round up. So I'd just like to thank all of our panel again for being such fantastic panelists, really great explanations, really appreciate your experiences that you've brought to the table, and also thank you to all of our fantastic audience. We've had some great questions, really interesting discussions stimulated from your questions and your ideas. This video will be on YouTube, so if you have a friend or somebody who didn't manage to see it, then you can point them in that direction once it's uploaded, and join us next time at our next ScotSci event, where we'll be discussing some more great science. So with that, I'll just say thank you very much and bye.
Thanks everyone. Bye.